Well, welcome everybody to our show today. My very special guest is Dr. Peter Staats. And Dr. Staats has a prolific history with an innovator and mover changer in the world of pain in the medical world. He started his career at Johns Hopkins. He was director there for about 10 years and then went on to do other things, developing treatments that are leading edge across the world. And we were just talking about vagal nerve stimulation is a new technique in Canada that's just been approved, and also in Scotland. So we're going to talk about different things today, and I'm going to let him introduce himself a little bit as well. But Peter, welcome, and thanks so much for coming on today.
Well, thanks so much, Wayne. It's a pleasure to be here. I was telling you that I just watched your TED Talk, and I'm somewhat humbled to be on your show, and I appreciate the opportunity. In brief, I'm a simple country doc. I started off at Johns Hopkins. I started the pain program there, became very interested in pain and neuromodulation. And over the years, I've served as president of the North American Neuromodulation Society, the American Society of Interventional Pain Physicians, the New Jersey Society of Interventional Pain Physicians. Today, I am president of the World Institute of Pain. I'm chief medical officer of National Spine and Pain Centers, the largest pain practice or integrated network of pain physicians in the US. I'm chief medical officer and co-founder of a company called electroCore, which makes a non-invasive vagus nerve stimulator. And then I spend a lot of my time working on Wounded Warrior Project, trying to help our veterans, as well as survivors of COVID and Survivor Corps, working on strategies to help those suffering from this new disability that we're going to see facing us. But thank you.
Okay, so let's go back in time a little bit. You mentioned before we come on about 1990, when you came up with this concept that pain was related to an emotion. Let's talk about that. Why did you think that back in the 90s?
So it's an interesting conversation, and I had a somewhat unique advantage. My father was really the predecessor of what we call cognitive behavioral psychology. He came up with a field of psychology called psychological behaviorism, which mechanistically tried to explain cognition and behaviors and biology into a unified theory in psychology. And today it's really the only unified theory in psychology. And when I became a pain doctor, the status of pain patients was either cut it out or ignore the behaviors and they will go away, a strict, what they call radical behaviorism approach. When I went over what I was seeing and the inadequacies of our paradigms, he said, you know, they got it all wrong, because they actually had been using his work. And we wrote together a new theory that really conceptualized pain as an emotional response. And with that, it really has a variety of implications. And you dove into some of them in your TED Talk, which I love so much. Whereas words that we say to ourselves elicit an emotional response. And those positive words and positive concepts can be ameliorating a pain, or negative self-talk can actually make pain worse. And we showed that in some studies that we did together back many, many years ago. But that's how it all got started, with trying to mechanistically explain pain from a psychological, cognitive, behavioral, and biological perspective many, many years ago.
And that must have been about the time that Candace Pert was doing her research with emotions and neuropeptides, and showing that, yeah, these emotions are not just fleeting things that happen. They're actually chemical reactions. They're proteins in the brain that are developed, or they result in proteins being developed in the brain that go on and program us, you know, mentally and as well as psychologically.
Well, yeah, I mean, you know, even deeper and farther back than that was in the field of psychology. There was the behaviorists, what people think of as Skinner and Watson. And then there were the classical conditioning people that people think of like Pavlov.
Yes.
And they were both really not complete. Both of them ignored the other. Yeah. And really, for something to function as a reinforcer, it's got to elicit that emotional response. And so everything is linked. And then what we said is we followed up on that and showed that the same area of the brain that is processing pain was the same area that processes emotions and depression. And so there really was this close link that had just not been fully appreciated back before we started to write about this.
Okay, so that was a long time ago now, but then you've been involved with the more hands-on physical side of things as well, right? So how did that tie in with your career as you went forward with neuromodulation?
Well, I think I became interested in neuromodulation, just the fascination and the magic of turning electricity and just turning off somebody's pain. I could implant an electrode on a nerve, set a frequency out there, and it would magically turn off the pain. And I became very interested in how that happens and the surgery and then the application of that, and became the first anesthesiologist with surgical privileges at any academic institution to implant these devices. And that whole aspect of my career moved forward. The whole aspect of my career about thinking about psychology and emotions moved forward. And then the vagus nerve hit. And that kind of brought a new facet in for me. And the reason I started to become very interested in that is my son had peanut allergies. And I was looking at a way to modulate the nervous system to open up the airways in an area of significant trauma or anaphylaxis or asthmatic attack. And we actually figured out how to do that by stimulating a nerve called the vagus nerve in the neck, the longest cranial nerve. And while we were figuring that out, a lot of other mysteries started to unravel for me about medicine, about psychology, about how we deliver healthcare together. But I think there were all little foundations that I needed to have gone through to get to where I am today, to understand what I think I understand. And I'm still learning every day, but what I think I understand about the power of the vagus nerve and what it does and why it's more than just that structure that gets in my way when I have to place an internal jugular access catheter for surgery.
So for the purpose of our audience, who are just the public, or the public with no or very little medical understanding of these deeper subjects, what is the vagal nerve?
So the vagus nerve is really one of the most powerful nerves in the body. And I think about this nerve as the nerve structure that controls the gut, the lungs, the heart. And we've known that for a long time. But it also controls a lot of brain functions as well. One way to think about this is when one stops and considers the mind-body interface, something I know you're very interested in, you have to ask, how does that happen? Does it happen through a chemical? Does it happen through an electrical pathway? And the truth is, one of the main aspects of mind-body medicine is, in fact, the vagus nerve. It is that central pathway that controls the information transfer between the brain and the rest of the body. That's the number one set of nerves that does this. Another way of answering this is there's a sympathetic, the fight or flight response, and that's the fight and flight. And then there's the parasympathetic, which is just chill out, dude, relax a little bit. And in our world, we spend way too much time with the fight or flight and not enough with that chill out aspect. And this is what the vagus nerve does so well. It tells you to relax.
And what I've liked with your answer, Peter, is not just the gut brain connection, because that's very hot topic with food and inflammatory foods and leaky gut syndrome and that side of things. But what I haven't really heard people talk about is, and as you said, the heart and the lungs, and other organs as well, is controlled or connected to the brain. So you got your peanut allergy and the lungs are closing up and you can't breathe or whatever may be going on. It's like, yeah, that's the vagal nerve dysfunction. It's not working properly, right? And we need to reverse that.
But there's another little nuance here that I think your readers might, or your listeners might appreciate, is that the vagus nerve scientifically controls inflammation. There's something called the cholinergic anti-inflammatory pathway. And this nerve goes to your spleen as well as to other areas in the body and can turn off an hyperinflammatory state. We just now have finished up a paper looking at patients with acute COVID, whereby we stimulated the vagus nerve in patients with acute COVID, and we're able to show the C-reactive protein, one of the modulators of inflammation, was able to be dramatically depressed pretty quickly with vagus nerve stimulation compared to standard of care in a group of hospitalized patients in Spain.
Wow, that's impressive. First time I've heard of this cholinergic anti-inflammatory pathway. Makes sense. And I do wonder, well, how does it all work? Because I know it works, you know, there's enough research out there to point towards it, but what is the biochemical pathway? So is this just within the vagal nerve, or is there other aspects to this nervous system pathway?
Well, the cholinergic anti-inflammatory pathway really refers to the vagus nerve, which sends a branch to the celiac nerve, which sends a branch to the spleen. In the spleen, the celiac nerve can activate T cells. You've heard about T cells with COVID and inflammation, but it activates T cells to make acetylcholine to go on to the microglial and the glial cells. And that's where those cytokines that you hear about in the cytokine storm, that's where they all come from, or a big portion of them come from. And so this is a pretty well mapped out pathway that's been identified. And what the vagus nerve and what we do now with the non-invasive vagus nerve is we tap into that system. It's access to the vagus nerve, as I described to our military folks here, is they're used to looking for access for blood and for other types of things. And this is a way of accessing into the vagus nerve, which we're learning is so incredibly powerful.
Mm-hmm. So you've taken the knowledge and you're now involved with this company that's developed a non-invasive approach to doing the very same thing. So let's talk about that a little bit.
Yeah, so the company that I'm involved with really started with a percutaneous approach and rapidly figured out a way of stimulating the vagus nerve non-invasively. What does that mean? Basically, we no longer need to put a needle into somebody. We no longer need to do surgery, but we can take a little bit of conducting gel, place a device over the neck where your vagus nerve runs, turn it on, and stimulate the vagus nerve to do a variety of different things. Mm. In the US, the FDA has cleared this device for treatment of episodic cluster headache, prevention of cluster headache, acute treatment of migraine, prevention of migraine, a treatment of migraine in adolescents, most recently treatment of hemicrania continuum and paroxysmal hemicranium. All of these are primary headache disorders that can be incredibly disabling and painful. And there was also an emergency use authorization granted by our FDA for airway reactivity thought to be due to asthma worsened by COVID. So they've recognized that this is a pathway that we can use as a treatment for home or in a healthcare setting for some of the patients with COVID as well.
And how available is it to, one, the medical setting, and then two, the non-medical setting? This is your host, Wayne Phimister. Thanks for enjoying the show today. Today, I'm advertising my Healing Chronic Pain course. Now, it covers the new science of how your brain can heal pain. It covers the heart-brain connection, as well as the gut-brain connection. Also, I dive into inflammation, how you can heal that, and optimize movement as you move towards a new reality in your body. So check it out on the link below. Enjoy the show.
Well, it is a prescription device, so a physician will need to prescribe the device, but it's available in the United States, it's available in Canada, it's available around the globe. And my colleague who runs the international group, we were just kidding him the other day that the sun never sets on his empire because it's approved really all across the globe. And certainly there are countries that we've not gone through the regulatory pathway yet, but it's really much more widely available now.
And so is it being used just for the COVID situation, or is it branching out into these other domains like pain?
Yeah, so the number one area that it's used is for the primary headache disorders that I've described. Now, across the globe, there is what's called a CE mark in the UK, for example, and there's asthma, epilepsy, anxiety and depression, gastrointestinal disorders, as well as primary headache are have an approval via the CE pathway for the UK. So they're tapping in a little bit earlier than we are in the United States on some of the scientific potential of these types of approaches of stimulating the vagus nerve.
Amazing. Wow. Well, it's brand new information for me today. Great. So, so if people are interested, can they just directly contact the company, or do they need, you need the prescription from you?
Sure, but they should, if they're interested in learning more about it, go to electrocore.com. And there's a pretty good website that has a lot of the scientific foundation of what we do. You know, it's very typical. We really only can talk about what's FDA approved and FDA cleared on those types of websites. But I think the rest of the world is coming around to that there's going to be a lot coming in this area. As it happens, I had to give a presentation the other day, and I wanted to just make the point that this isn't me coming up with this. I wish I could take credit for it, but there are something like 10,800 articles that have been published on vagus nerve stimulation for a variety of different indications. To the satisfaction of the FDA, in the United States, the only thing that's been approved for are the primary headaches that I've described and the emergency use authorization note.
Wow. Okay, so where, you know, if you just put in your glasses for the next 30 years, please, where do you see this going?
Well, I actually believe largely in two separate areas. Number one is we have clearly identified that medical devices are a mainstay of healthcare. For example, if you have a slowed heart, what we call bradycardia, what does the doctor do? They may try a medicine, they may want to understand the pathophysiology, but they're going to put in a pacemaker. If you have a severe movement disorder, they'll place what's called a deep brain stimulator, a device in the brain to stimulate an area of the brain to help you with your movement disorder, like Parkinson's disease. If you have severe chronic pain, a spinal cord stimulator is frequently implanted. If you have urinary incontinence, they may implant a device to help with incontinence. And I think we're going to get to the point where the vagus nerve stimulation is going to be considered a mainstay of therapy for a variety of different disorders. And people are looking at this in a new light now. One of my colleagues, Michael Hoffman, down at the VA in Orlando, describes the brain as not just a chemical organ, but an electrical chemical organ. And this is the most elegant way of tapping into that organ right now, using a discrete pathway of vagus nerve stimulation. We're going to be looking at a lot of things. There was a paper published recently on Parkinson's disease, showing changes in brain-derived nerve growth factor in the brain of Parkinson's. Not only are they improvement in their gait, et cetera, but the brain factors are different. I think we're going to be looking at this for attention and alertness. The United States Air Force has done some work that they published in Nature Communications earlier this year, showing that stimulation of our soldiers in a sleep deprivation setting improves their sense of fatigue and decreases the error rate on certain types of tasks. We're going to be looking at this for gastrointestinal disorders and cardiac disorders. I think the vagus nerve is going to turn out to be one of the most incredibly powerful structures that we'll be able to tap into and really make some difference.
Wow, fascinating. Makes a lot of sense to me.
Yeah,
definitely the way forward. Okay, so anything you want to ask?
Well, I just think, I wanted to just commend you on your TED Talk. I think I may have mentioned I really enjoyed your TED Talk, and it was such a wonderful presentation of how we should be thinking about disorders from a psychological and a biological perspective in a unified approach. You really nailed it. Just wanted to commend you on that.
Well, thank you. And just a question on that subject: are you working in your clinics, and are you seeing this multidisciplinary approach with the mind-body connection involved with the invasive or non-invasive approaches, more the hands-on medical devices approach? Are you seeing that yet?
Yeah, so the term multidisciplinary pain clinic really referred back to the University of Washington in Seattle, where every specialist would come in and see every patient. And I never actually really thought that was the right strategy. What I implemented at Hopkins and what we have in our programs is what I would call an interdisciplinary.
Yeah.
Where the physician is the captain of the ship, but they really have to understand the waves, they have to understand the winds, they have to understand their ship, they have to understand the entire patient aspect of things. And so we should be liberally using psychological interventions. We should be liberally thinking about other types of strategies to come up with a best strategy for a given patient. So in essence, the answer is yes. Start with making a diagnosis, and that diagnosis includes your psychological health as well as your biological health. And I would also add in the comments that you made about self-talk. That's been lost on physicians, and your comments for your audience was make sure that you're saying positive self-thoughts to yourself and self-talk, because that's incredibly important. And part of our message as physicians should be to heal people, not to just treat them as a disease in front of us that needs a particular intervention. They need a more comprehensive approach. And I believe the physician should be a big part of that.
I think that was one thing for me back about 5 years ago when I came across this work, and I started very cautiously to say to people, look, you got to change what you think. You got to start believing it. You got to just repeat it. I didn't know what I was saying to them. I didn't really have any experience other than what I was reading around John Sarno and and other physicians like that. But what I found, just as a general GP in the trenches doing my day job, was that people were very receptive to that. And they just, if the physician believes in it, if the physician is going forward with it, then it's possible.
Yeah.
But unless the physician has had an experience of this, or you had your own personal journey that led you to where you are, and I've had my own personal journey to lead me to where we are. But unless the grassroots physician starts to take this board as just normal physiology, not even pathology, but physiology, thinking equals emotions equals neuropeptides equals brain formation, brain cell creation and development and change and healing, as you mentioned, healing. And
yeah.
It's a fearful thing for us to embrace. That was my experience. But if you just go through it, and the more and more that we share this and speak about it, it becomes more normal. Then it can be there's my son coming in for food probably. But the more we embrace this and believe in it and start seeing results, as I did in my pain talk on TEDx, was Julie Claire, a lady, 49 years, had chronic pain, and she was desperate. She traveled 3 continents on opioids for 49 years. Her leg was amputated due to a gunshot wound complication when she was a teenager. And she took on that affirmation every day in every way. I'm getting better and better. And she believed it with her whole heart, day and night. She was literally dancing with one leg and a prosthesis around her living room, believing this stuff and hoping for it. And 4 weeks later, as I said, the pain was gone, and it hasn't come back. And that's 3 years later. She still has pain in other areas, but that specific brain connection has been circumvented and changed. And now her body is doing what it's meant to do, which is be pain-free. So,
when I started working on that back in the early 90s, I did some tests with college students called the cold presser test, where we asked the college students to put their hand in ice water and think about positive thoughts or negative thoughts. And what we found was if they thought about negative thoughts, their tolerance, endurance, and threshold for pain went way down. If they thought about, if they thought about negative thoughts, everything went way down. If in fact they thought about positive thoughts, positive self-talk, their tolerance, endurance, and threshold went way up. They really were able to, in a very short 15-minute setting, were able to dramatically alter their experience of pain. And it was studies that we were doing, trying to understand the mechanisms of the placebo effect when we were doing that way back when. And my claim to fame is that the BBC picked this up. They called me one day in the mid 1990s and said, so Dr. Staats, what is a positive thought? And much like you talked about the tea and, drinking your tea and having a nice positive thought, and I said, walking on the beach. And I said, if you're hungry, thinking about food. And I went through a list of words in our language that have elicited positive response in people. And we've shown that over the years in psychological studies. And they kept pushing and they said, so what else? And I said, yes, you guessed it, sex. And of course, that was what was picked up by the BBC, the National Enquirer, and of course, Penthouse. So my 15 minutes was a little bit of a misquote that said, thinking about sex relieves chronic pain, says excited researchers from the famed Johns Hopkins Medical Institution in Baltimore.
Oh, wonderful. Nice little story there. Perfect. Okay. Well, any simple messages to our audience today from the wealth of your experience?
Well, I would say number one, all pain is real. If you're getting information from your physician that says they don't believe you, then you need to find a new doctor, first of all. Now, there is times when the brain processes pain very differently, and they may recommend psychological help, etc. But that doesn't mean it's not real. And continue to search for the answers, because for the most part, when we haven't found an answer yet, it's that we've not made the right diagnosis, or we need to have yet another test. And I have a slightly different approach than a lot of people who say, stop thinking about it, just forget about it. I think we do need to make a diagnosis, come up with the most rational therapeutic plan, and then integrate all of the things that you so nicely talk about in your TED Talk.
Well, thank you for that. Exactly. Never give up. Never give up. It's definitely my message as well. That's why I do what I do, and I find out what I found out over the years with fascia and inflammation and all these different things that I get involved with. So thank you so much from the depths of my heart that you've been able to come on here and share. And it's a privilege to meet you, and also to get you to talk about your world and what's happened to you and your journey for the last 30 years plus. So thanks so much, Peter. Wonderful to see you.
Thank you very much, Wayne. I appreciate it.